All right, what do you think, Karen? Should we start?
Let's get it going, girl.
Sounds good. So thank you everybody for joining us tonight. I am Wendy Golden. I'm an endodontist in medical affairs for Sohn Endo. Let's review a little bit about tonight's webinar. Tonight we're going to learn what factors impact the long-term prognosis of endodontic cases. We're going to review the mechanism of action of the gentle wave system and also look at some difficult endo cases and learn how gentle wave helps us save more teeth. Tonight's webinar does include 1.5 CE credits, so let's just quickly review the CE process. One, you must be registered for the event. Your attendance is going to be recorded via Zoom. Make sure that your full name is visible under your Zoom profile, and if it's not, just put it in the chat for us. We are going to send you a survey via email. We ask that you send that out and get that back to us. And once we receive that, we will send you your CE certificate. If you have any questions along the way, please reach out to myself or education@sonendo.com. So tonight is going to be an interesting webinar. We want it to be very interactive. Your questions are deeply encouraged. We're going to leave some Q&A after the presentation where you can come off mute and hopefully come off camera and ask Karen some direct questions. And then during the presentation, Karen's going to be reviewing some cases. And during that time, if you have questions about that case and if you want to enter them in the chat box, I will ask her those questions before we move on to the next case. So again, during cases, please put your questions in the chat box. We're also going to be doing some polling tonight. So we're going to just do a demonstration of what a poll looks like. So tonight, if everybody could just enter in where you're located, and then you're going to hit the submit button down below. And we will show you who's tonight on the webinar. With an answer that might pop up here in just a second, where everyone is located tonight. Here we go. So very nice, kind of all over, which is awesome. I love that we're getting even some Canadians. This is awesome. So that's how the poll is going to work tonight. It is my pleasure to introduce you to a dear friend and colleague, Dr. Karen Potter. Karen graduated from the University of Iowa. She owns her own practice in San Clemente, where she was born and raised. Karen bought her gentle wave in February of 2019, and since then has completed over 3,000 gentle wave cases. So Karen, I'm going to turn it over to you.
Great. Thanks, Wendy. Just take me a second and we should be ready to roll. All right. Hi, everybody. Good evening. Thank you to everyone for joining. I know it's late where some of you are, 33% from the Eastern United States. So I appreciate you guys staying up late. I just got done with my day of cases and had to kind of freshen up a little bit to be here too. So today our topic is toss or treat. We're going to have a little Halloween theme. It's one of my favorite holidays. And we're going to talk about saving even the spookiest teeth. So with that, let's get started. Let me see if I can get this going here. Why is not? Okay. There we go. So my disclaimer, obviously these are all my own cases. They are all my own opinions. I definitely respect that we all have our own opinions and we treat things differently. And that's actually the topic for tonight. Like, how would we address a certain case if it's complicated or spooky? And we're all going to have different ways of doing things. These are my ways. And I'm just happy to share with you the way that I treat, but I'm also a lifelong learner. And I appreciate that we all do things differently. So I would love to talk with you guys another time about how you do things because I'm always looking to improve as well. Also, I'm a consultant for Sun Endo. I'm a KOL. I've been lecturing for a few years now, and I really do love the gentle wave. That's why I talk about it. All right. Wendy gave me a little background. I'm from San Clemente, California, born and raised. I went to USC, Flight on Trojans. I then went to UCLA, see some of my co-residents or classmates. Jason, I saw your note. Thank you. And then I went off to University of Iowa, where I met my husband, brought him back to San Clemente. I've been a diplomate since 2011. And I've been in private practice since 2010. So I'm here to just share with you my knowledge. Like Wendy said, I've been using Gentle Wave since early 2019. I've done thousands of cases. I use it exclusively. There's only been maybe a handful of cases in all those years I haven't used it on. And so I've honed my skill over time. The way I practice now is very different from the way I practiced day one of my Gentle Wave. So we're going to talk a little bit about it. All right, trick or treat, toss or treat. All right, we're going to talk about these teeth that are more questionable, that maybe some of us might approach differently than others. And we have to acknowledge straight up that clinical decision making is one of the hardest things we do as specialists. Okay, we are the experts. I'm not sure how many GPs are on this, but you guys, GPs, they refer their cases to us because they trust us to know the best thing to do and to be able to guide the patient. Okay, determining prognosis. How many times you get a referral that says, can this tooth be saved? Okay, they're letting us help decide that. Looking at the cost benefit ratio, dentistry is not free, at least here in the US. So, looking at the amount of money that the patient would be investing and the benefit that they will be receiving, trying to maintain their tooth long term, and the patient's motivations. Some people really want to save their teeth. They believe strongly in saving their natural dentition, and other people, they can't, their motivations are financial or they just don't care. So let's look a little bit at these different factors. And, we look at these teeth that we can see the complexity of the teeth, very well demonstrated here. And our job is really hard. We have to essentially try to predictably clean out all of this space. And there are some teeth that are much harder than others for obvious reasons, like you can see them on the screen. And, it can be hard and daunting at times to try to treat a tooth that maybe has a large apical lesion or deep caries, teeth that are periodontally involved, teeth that are calcified, maybe a retreat that looks like they didn't maintain the anatomy properly or it's super curved, or maybe, you know, they have a big perioendo lesion that just looks daunting. Maybe it's had apical surgery already and there's still some defect there or a sinus tract. So, is it worth the money? Is a new crown going to be necessary? Is it a gamble? How much do your patients like to roll the dice in some of these cases? So we're going to discuss all of that today. When we have a decision in front of us, whether it's a tooth that's never been endodontically treated or a tooth that has, but has endodontic treatment that is failing, this is kind of our decision tree. I know there's other options for for failed endo. I know like people do root amputations, all those things. But in general, for this lecture and just simplicity purposes, we're going to talk about these decisions today. When it's a case that has not been previously treated and it's either has pulpitis or necrosis, we're going to talk about, do we do a root canal treatment or do we extract the tooth? If it's a failed endo, do we retreat that case? Do we do apical surgery? Sometimes a combination of the two, or do we recommend extraction to our patients? This decision tree can be very difficult and it's multifactorial, right? So there's the factors that we look at every time we see a PA, a bite wing, and a cone beam CT scan, and we clinically assess a patient. We think about etiology. Why did this pulp become inflamed or become necrotic? Why did this root canal fail? Is it a crack? Is it a deep decay, coronal leakage? What is the etiology for this root needing work? Is it restorable? Okay, I always tell my patients I can do a root canal on almost any root in the mouth. If I can isolate it, I can do a root canal, but is it worth it? Is it restorable? Is it going to predictably be able to serve that patient for years to come? If it's not, or if the doctor that I trusted me with this patient can't restore it, then maybe we don't do the root canal. Periodontal condition. Is there moderate to severe periodontitis? Is it vertical or is it just completely horizontal bone loss that the teeth are all mobile and they're all gonna, come out at some point? Periodontal condition affects our decision making. So does maintenance of the canal architecture in a failed case. There's a famous study, Classic Lit, that says that the maintenance of the canal architecture, if it's completely ledged or a straight canal, but the root is curved, it's going to be much more difficult for us to retreat that case. Maybe then we do surgery, or maybe now we use gentle wave on it. Iatrogenic complications. Did the patient present with a huge access that perfed or a separated instrument? Is there something that was done prior that is going to complicate the success rate that we will achieve, even as skilled clinicians? The cost, is the crown going to need replacement? Can the patient afford to get a root canal and a crown? Do they have insurance? Do they not have insurance? These are all factors to play into the way that we talk to our patients about making an educated decision. Other factors, systemic health. Has the patient been on bisphosphonates? Have they had radiation to the head and neck? Do they have dry mouth? Do they are they 97? Are they 27? The age. These are all things that impact our decision making and our guidance to our patients to help them have autonomy and make an educated decision. And then finally, the main thing, and when you factor all these things in, what is the prognosis? What is the likelihood of success? I always tell my patients, I can't guarantee that this will heal because I can do my best work and I can go 50%, but ultimately your immune system and your body has to go the other half. So if I do perfect work and your body for some reason can't heal, then we may still have failure. So even though we have a high success rate, or maybe in a case that doesn't have as high of a success rate, the prognosis and these factors are things we need to consider when we encourage our patient to save their tooth. So we're going to take a poll really quick because this is going to introduce the polling to the group. This is a case, it's an 80-year-old man, tooth number 23. Sorry, if you need to move that poll to see the cone beam a little better, you're able to move that. I believe you're able to move that polling window. But essentially, we are going to look at this tooth. He's asymptomatic. It was seen on a PA. The crowns are old. And the tooth is slightly mobile. He has no response to percussion, biting, any of that stuff. And probings are deep, but in general. So we've got 5-6 millimeter pocketing on the buccal and lingual, and interproximally the bone is better. So how are we going to treat this case? What would you do? And if you scroll down, and I'm going to do it too, so I can make sure that our options are retreat, do apical surgery, or extract. Now, mind you, this is a case that has kind of a perioendo type lesion, not much bone supporting it. The root canal is inadequate. You can very clearly see that. But there's so many other factors that we just talked about that in your mind you might consider. So let's go ahead and do the poll. And a few more seconds. And then Vivian, if you could please show us their answer. Okay, so 91% of us said we would retreat this case, okay? And 9% said extraction. Now, I'm guessing that the people that said extraction looked at this perioendo component and it was considering the prognosis that there's really no buccal or lingual bone, very minimal lingual bone, no buccal bone holding this tooth into the jaw, thought there may be, a difficult time regrowing and regenerating all the bone. Okay, so turns out this patient was old. He didn't care. He wanted it out. He's not paying the money. He's not sitting through the procedure. I would have also retreated this case, by the way, but he opted not to, and he's going to have it, or he already did have it extracted. All right, so that's how we're going to be working our poll. Thank you for all participating. Now, we have great diagnostic tools. We have CBCT, we have good microscopes, we have lots of great technology to help us assess etiology and all of those things. But we also have, interestingly, this assessment form by the AAE and an EndoCase app that talks about multiple factors that we can look at when we assess the difficulty of a case. Because when I think of a spooky tooth, I think of a tooth that is considered difficult, high level of difficulty in all of the categories that the AAE has published, okay? And while most of us as endodontists are really only working on moderate and high level of difficulty cases, this is a great tool for general dentists to decide when to refer. So if you're a GP and you don't know about this, please check it out. It's pretty cool, and it helps you determine when it might be appropriate to refer. Now, as an endodontist, I look at this chart and I look at these spooky cases that are in the high level of difficulty column. So, for example, I look at a canal morphology column and I look at C-shaped canals. I look at extreme canal curvature, mandibular premolars or anteriors with 2 or 3 or 4 canals, maxillary premolars with 3 roots or canals. The canal has a middle or apical third bifurcation, or a 2-1-2 bifurcation, a very long tooth, and then other anomalies, as in extra roots, etc., and then an open apex. In addition, we can look at radiographic appearance of canals, like calcification, if the canal chamber or the canals themselves are not visible, if there's a fast break, meaning the canal splits and just kind of disappears, but it's probably bifurcating. Those are high levels of difficulty. Those are what I consider spooky teeth. Also, trauma, history of trauma, so immature roots, horizontal root fractures, all sorts of trauma, luxation, avulsion, that's all by the AAE considered high level of difficulty. And at treatment, endodontic treatment history. So these are the cases that have been treated or initially accessed, so previously initiated treatment that maybe had complications or maybe haven't had complications, but are still complicated in their anatomy, or a previous surgery, or already have been retreated at least once. And then again, very important perioendo condition, whether the patient has periodontitis, just generally speaking, or a vertical periodontal defect that we can't tell if it's a fracture or just a really bad perio defect, cracked teeth, etc. These are spooky teeth. So these cases are those cases that are difficult to treat. So what about treating them? Because we all want to save teeth, as many as we can. Well, these factors that we just reviewed in the last 6-7 years, 6-7, sorry, whoever has a teenager, as a general wave user, I have basically eliminated many of those as being spooky to me. Okay, so the general wave and its technology, it helps take away some of those factors that historically we would find spooky or difficult, and they used to maybe influence our assessment of prognosis, but now have taken away those factors for me as considering as a difficult tooth or a prognosis that may be more questionable. Okay, and we're going to just briefly review, because I think Wendy said almost all of us have either looked into Gentle Wave or are new users or experienced users, just how it works. And you've all seen this slide: cavitation bubbles, continuous irrigation for 8 minutes, and the most important, in my opinion, #1 factor that differentiates is the degassing. So it's just the only thing that separates Gentle Wave from all the rest is the degassing. And I really do believe that that makes a huge difference. So we use the Gentle Wave. We have cases that we can treat now that we would originally or previously historically think were spooky, and now we can treat them very predictably. So let's get into it. Um, we're going to review some cases. You may notice a theme here. My family is a Halloween family. What does that mean? It means that for 14 years, we have had a themed costume as a family. And also, my house is crazy on Halloween. Crazy. My son and my husband have both bought and created with their own imagination and hands. Um, I would say 3 to 4 dozen Halloween decorations or props that we have on our front yard. So, we're gonna have a little picture of my family to kind of transition each case. Sorry if it's overboard, but you'll get the sense for why my family loves Halloween. I also got engaged on Halloween, by the way. So, we're going to start with some cases. So, the first case that I'm going to present is a case I love talking about because this case is very spooky. When I first saw it, I thought, oh, this is my web developer who called me one day and said, Karen, I went to my dentist who did 2 root canals on me a year ago, and he says I need 2 implants. Um, and I remember when I did your website that you are an expert in saving teeth. So I was wondering if I could have you look at my teeth. And I said, absolutely, come on down. It was like a 45 to 55-minute drive for him, which for some of you more rural endodontists, I know is nothing. But for Southern California, there's probably 30 or 40 endodontists between me and him. So he came down to San Clemente and we looked at this. I said, listen, we have multiple problems here. We have bad, horrible crown margins, brand new crowns, 1 year old. We have apical lesions on 19 distal root 20. We've got a post in distal root of 19. We've got a separated file in the distal root apex of 19. This is just all in all, in that AAE assessment would be high difficulty from top to bottom, okay? And he said, well, okay, but can you save them? And I said, maybe. We'll give it a try. If you want, I'm on board. We'll give it a try. But first, go get those crowns taken off and come back in temporaries because I don't want to work through this work. So here's the cone beam of what we saw. We have a lesion on 19 distal and on 20. And there's definitely a separated tool in that distal canal. And he wanted to try. So, what we did was he came back and first of all, how would you have addressed this? Let's do a poll. This is something his dentist saw on a PA. He had done root canals the year prior, due to decay, pulpitis. Okay, good. All right. So thank you for answering. Most of us would try to retreat both teeth, probably 4%, maybe some very highly skilled surgeons who love doing apical surgery. Wouldn't want to get caught in this mess, would just lop off the ends of the roots, do beautiful little retrofills, and they would heal beautifully because surgery heals. It's so good. And then a couple people would extract the molar because probably the separated file is my guess, and then retreat 20. So I would say that all of those are fair ways to assess. And my patient, he wanted to try to retreat because he knew from my website that I had this cool technology. I said I probably can't take the file out, but I may be able to clean past it. Okay, so I'm going to walk you through how I treated this case. Some of these pictures, clinical pictures, are not this specific case, but I want to just demonstrate what I do. So this is how I isolate my rubber dam. I use a split dam, so I'm going to isolate the tooth distal to where I'm working and the tooth mesial to where I'm working so that I can remove all decay, I can have a perfect view, I can build a platform, I can do everything I need to do without rubber dam clamps or any decay or anything getting in my way. If I'm working on a second molar and there's no first molar, third molar, obviously I clamp the tooth I'm working on, but I still bring it up a couple teeth so that I have a good field of view. This is how I manage interproximal gingival crevicular fluid. I remove all decay, and a lot of times that gum is really inflamed, right? So I use a Cavit matrix, which I've lectured on before. I just wanted to put a quick slide in here which basically shows that I take a little hot dog of Cavit, I stick it interproximally, I tamp it down with a slightly moist cotton pellet so that it covers all soft tissue, and then I scrape any Cavit away from my dentin so that I have a nice dry dentinal surface adjacent to my canals. I use this on any case that has subgingival decay, so I end up doing it at least once, twice a day, and it works consistently and it's easy to remove at the end of the procedure. So if you've never tried this, you should definitely give it a try. This is my setup. My sponge has an 8, 10, and 15 21 millimeter file. It also has an 8 and a 10 25 millimeter file. Those are the files I use. I can ask for 6s if I need them, and sometimes I do. And then my sponge, my rotary sponge, has a Avalon Biomed Slim Shaper ZS1 and 2 that I use. Those are the only files I use. And then a Munspur, a 10 size purple Munspur, which I love. I use for every single case. The other things on my tray are my locking pliers with my matrix in it, and 2 tubes of Sound Seal, one with a white MAC tip from Ultradent and one with a black mini tip. Sometimes, if needed, I will pull out a black micro tip. I don't use it typically because it's really hard. I have to put a lot of pressure, digital pressure, to get the material out. But I do use that sometimes if it's a very deep or very small area that I have to gently place Sound Seal on. And once I have all this set up, I can proceed with my root canal. I will access the tooth. In this case, remove the gutta percha and post, but in necrotic and vital cases, I will simply get working length and use my 2 rotary files. And then once those canals are kind of debulked, so to speak, and shaped to the smallest size that I think I can fit a gutta percha in, I will build my platform and run the gentle wave. Okay. So this is me running the gentle wave, but more recently, I have now delegated this job to my assistant. This is Taylor. I have 3 assistants that can run the gentle wave for me while I go drink my mom life cold brew. So that's me relaxing, charting, taking a break, drinking some caffeine while my assistants are doing my gentle wave procedure. When I'm ready to obturate after the gentle wave, I just dry my canals. I don't get a lot of bleeding. If you are getting a lot of bleeding with gentle wave, you're probably over instrumenting. So minimal instrumentation, very rare to get a lot of bleeding. I use maybe 1 or 2 paper points and that's it. And then I inject sealer into my canals, BC high flow. And I place my cones into each canal as long as they fit where I want them to fit. I take a film. I take my check film, and if everything looks good, I'm ready to sear and obturate. I sear slightly below the orifice because my taper is pretty narrow. I don't get very far down below the orifice with my heated plugger. It's just a size thing. It just prevents me, the narrow taper prevents me from going too deep. And then I condense apically what I can backfill, I do to the orifice itself. And this is the product I use for that. Once I did all of that for this case, this was my final result. I was not able to remove the file, but I got sealer past it, which I'm going to make the assumption that I was able to clean past it. So, and I also got this lateral canal on number 20. And I told my web developer, hey, this looks good, but let's see how it does. So he came back 18 months later and everything had healed. He was asymptomatic. I still don't love the crowns, but the bone was intact and healed. And here's a comparison, pre-op cone beam and 18-month cone beam. We can very clearly see that he is healing nicely. Any questions on that, Wendy, before we keep going?
I'm going to pause here because even I had a few and see if
Really quick, there's one that popped up. Do you see that one? It said, was I able to bypass the file with an instrument? And the answer is no.
My question, Karen, have you ever been able to retrieve a file with Gentle Wave before?
Yes, once, but it was not in the apical third. It was in the middle third, and I was able to get it loose enough, and it did dislodge during the gentle wave cycle. But I've never been able to get an apical third separated tool out.
Once,
No, I don't have a post-op CBCT showing both distal canals filled, but I do have an 18-month CBCT, and I do have a PA that shows. This is the PA that shows both distal canals filled with sealer.
did you access through the permanent crown, Karen, on those?
No, I required him to have them removed before returning to me because I just wanted to pop the temporaries off and be able to do my work, get that post out as conservatively as possible. All right, case two. We got frozen here. Okay, this is an anterior case. The patient is asymptomatic, but their chief complaint is my tooth is discoloring. They don't really recall trauma, maybe, maybe not. They did have ortho, and she wanted internal bleaching. So I took a cone beam and actually noticed there's a lesion there. Um, but very irregular, very spooky calcification pattern. I was like, that's not looking good. Like, I wonder what I'm going to encounter in there because in my experience, when I have cases like this, I open it, I get into that pulp chamber, and then it's like a brick wall of just like mottled dentin. But I thought, it seems like I might be able to take a Munspur and just kind of trough out that dentin, that remodeled dentin, and hopefully get to that apical part of the canal because I could see that, it looked like there was some sort of canal space in the apical third, but the middle third was calcified. So these are my Munspurs. If you haven't tried them, no disclosures or anything. If you haven't just tried them, they're awesome. I basically stopped using ultrasonic during traditional root canal treatment. I still use it for surgery, but not for ortho grade. Reminders that, when we have an anterior case like this, we need to seat the matrix at the long axis of the tooth, not perpendicular to the axis opening, because it's very intuitive to think, oh, I need to stick it into the canal or if the access opening, which is on the lingual surface of the tooth. But actually, that's not how we want to do it, right? We really want it to be perpendicular with the long axis of the tooth. So that essentially means that we have to build up this cingulum area with Sound Seal to help create almost like an occlusal table on the surface of the tooth, on the incisal edge. And once we do that, we can seat the matrix straight down on the long axis of the tooth, and we are able to successfully run our gentle wave because we really want the mechanism of action to be as close to the long axis of the tooth as possible. I did that for this case. I unfortunately troughed quite a bit with my months. I was unable to find a canal in that apical third, and I was kind of starting to go a little off angle. So instead of taking my chances, I decided to run the gentle wave and see if maybe I could get some sealer up. I've seen cases, Jim Smith and other amazing people do those cases where they just, are able to get sealer up there. So I thought to myself as a backup, I can always do surgery because this is, number 10, so I can do surgery if I need to. So unfortunately, I ran the gentle wave. I was not able to get any sealer or anything apical to where I am right here. And I kind of like thought, oh, that sucks, but we'll just see how it goes. So I did bleach the tooth with sodium perborate and saline. I did it for 1 week, and this is the result. Here is a before and an after. We can see that, and obviously, her restorative is not great, but that tooth looks so much better. So, I was pleased. The patient was pleased. The doctor was pleased, and I ended up seeing her back in a year. And sure enough, the lesion healed. This is the miracle of the human body. So I was very pleased with this result. And, patient's asymptomatic, bone looks great. And the tooth is the color the patient wants. So, before I move on to the next case, any questions on that one? This next case, I'm going to share is a resorption case. I know resorption can be really spooky. So let's talk a little bit about it. And this is a technique that my buddy Scott, I know you're on here. Thanks for being here and for being my mentor. Taught me as far as really trusting Gentle Wave to treat resorption for us instead of mechanically removing it. So here's a resorption case. We have number 30. And whenever I look at these cases, I really need to um, study the cone beam to look at multiple factors and deciding how I'm going to approach the case. Because a lot of cases, they're root canal and surgery. Some are incipient lesions, they're just surgery. And some are too beyond what any of us could treat. So we either extract or we do nothing and monitor until it causes a problem. But a case like this one, where I will treat it endodontically and not do surgery, has to be a very specific case. And it has to be a case where the pinpoint portal of entry is very small and either at the level of the bone or slightly under, or at least in the attachment, the gingival attachment. It cannot be something that is above the level of the attachment because we'll have washout of our sealer. But what I do in cases like this is I access the case and then I get my working length. And before I even do anything else, minimal instrumentation, I run the Gentle Wave. I don't do anything with the resorption. And the mechanism of action of the Gentle Wave cleans out those osteoclastic cells that are in that resorptive defect so that when you're left at the end of the Gentle Wave, you look in this pulp chamber and there's really not even any bleeding because all those cells have gotten washed away. Okay, and remind you, these are pinpoint portal of entry cases. These are not gaping, huge resorptive defect where the resorption is mostly on the external surface of the root. The resorption is mostly on the internal surface of the root. So, with the case like this, once I clean out those osteoclasts and the pulp tissue, I can obturate and I do my canals first. And then, like Scott Hetz taught me, I fill the resorptive area with sealer and I lay hot gutta percha over it, let it cool, or even maybe sometimes put a endo ice soaked cotton pellet and I just tamp it down and all of that sealer just hydrodynamically goes into those lacunae, those like cell osteoclastic cell spaces that it's been eating away at. So this is a really cool technique. And if you haven't tried it, you should. I did not take a burr to this resorption at all. And this is what I ended up with. So this is a case that I unfortunately have not recalled, but my guess is the patient's doing great. I have other cases that were not as radiographically clear about what I did as this one that I have recalled and they're doing great. So, any questions about this technique? All right.
So Karen, a couple questions, just one on the previous case with internal bleaching. Someone was asking that sodium perborate is no longer, it's discontinued. Where are you getting yours and were you aware of that?
I was not aware of it, but I haven't had to buy it in a while, so maybe it's been discontinued recently.
Sure. Same here. I think that big lasts us a long time, right?
Yeah.
That box.
I'm sure
Okay.
maybe by the time I don't know why it would be discontinued. Can anyone come off mute and pipe in on that? Is there something that they've discovered that they think, I
Yeah.
mean, unless there's something that they've discovered about it, I have no hesitation at all using this material in my patients. And when we're done with our pack of it, I don't know, maybe there'll be an alternative option to use in that time in the future.
Sure. And then getting to this case, so they wanted to make sure, did you run gentle wave first and then instrument?
No, sorry. I debride the canals first, and but I just don't do any mechanical. I don't bore out or drill out any of those osteoclasts. I just um do my minimal instrumentation and I leave the resorption alone, and then I run the gentle wave, and it finishes my canal cleaning and my resorption cleaning simultaneously.
Great. How would you manage this if the resorption case, if the portal of entry is a bit larger?
So it depends. It depends how large. I will, if it's a little bit larger than this, I will still do this technique and I will see, um, kind of, I'll see how it fares. And if I think it needs to be flapped, we can always do that. If it's big, I don't do this technique. I just want to be clear on that. If we're looking at one of those saucerized, lesions that clearly have to have surgery, then no, that's a two-step. It's a gentle wave and a surgery, two different not necessarily two different procedures. I can do them at the same time. In fact, I was going to do show another one that I did do surgery on, but for the sake of time, I took it out because I wanted to focus on this technique.
Sure. When you described how you obturated the resorptive lesion, will you go into detail again a little slowly, how you do that?
Yes. So you've all seen resorption in the scope. It's usually because it doesn't typically break through the predentin layer, it's usually big in the dentin but small in the pulp, right? So wherever that breakthrough was, okay, wherever it breaks through, I'm going to inject sealer into that space best I can, and then I can, if I can get my heated gutta percha tip in that area, I can put a little in. But if I can't, I'm gonna spread it all around the area that broke through, and I'm gonna either let it cool, or if I want to speed up the process, I can take like in this case, I very well could have put gutta percha along the entire floor of the pulp chamber, let it cool with or tamped it with a frozen um cotton pellet. So you spray the cotton pellet, you push it in, that freezes the gutta percha, makes it hard, and at the same time it's getting hard, but you're pushing that pressure towards the area that you want to spread the sealer into, right? It's just like doing condensation, but it's into a resorption defect. If you pop a lateral, that's essentially the same thing you're doing. It's sealer in that lateral, most likely. It's not gutta percha, right? So it's a similar concept where you're trying to can basically hydrodynamically move the sealer into any open space.
And does it matter if you use regular or high flow?
I would use high flow
Okay,
because regular just has higher viscosity. It's not going to flow into those little, spaces as readily.
great. And then do you recommend with resorptive teeth, an occlusal filling or a crown after that?
Honestly, I refer back to my restorative doctors for all of that stuff. So usually if it's a posterior like this, they're probably going to crown it just for, occlusal forces. But if it's an anterior, no, it doesn't need to be crowned.
Okay.
No, I did not fill the entire chamber with warm gutta percha. I just did that to allow myself to tamp the sealer into where I wanted it to go, and then I can remove the gutta percha when I'm done. To clarify, you just want gutta percha at the orifice level. You don't need to fill the chamber with gutta percha.
And then, this is an interesting question. Do you think that this was completely internal resorption?
No. I could see on the cone beam that it was not.
Okay.
Plus, internal resorption doesn't look like this. It's not modeled. It's typically more uniform in shape. Next case, we got inside out. Alrighty. Number 18. Draining sinus tract. Patient's asymptomatic but noticed a bump on their gums. The dentist saw this, referred to me. 12 millimeter pocket at the site of the sinus tract. Here is a cone beam. So we're going to take a poll. How would we address this case? This is a pretty substantial perioendo lesion. 78% want to save the tooth. 22% would recommend extraction, probably because of the substantial amount of bone loss, making full healing less predictable, obviously. Also, risk of a fracture, because we also see bone loss like this if there's a distal marginal ridge fracture extending down the root. So that's why I'm guessing over 20% of people on this call would recommend extraction. Well, I've done many, many, many root canals on this patient, and there was no way in heck she was going to let me pull her tooth without trying a root canal. So we tried the root canal, and this was obviously a necrotic case, but we got a really nice result. We had a really bizarre kind of shape of the apical foramen on the lateral surface of the root, big sealer puff. But she came back 4 years later for me to do another root canal on her, and this is what we had. So no perio, no sinus tract, bone is healed. Patient is asymptomatic, didn't even know when I said, oh, let's take a recall on that root we did 4 years ago, which tooth it even was or why. And this case just kind of exemplifies how single visit endo with gentle wave works because it removes the etiology. And if the etiology is removed, we can get healing. The body wants to grow bone. So I have case after case after case like this. One of my very first root canal gentle wave cases was a single visit case similar to this, number 31 on the other side. And I think I have a 5-year recall for that patient, but it's been close to 7 years now for that patient.
Did you have any
Any-
hesitation in this, Karen, to do single visit?
Pardon?
Did you have any hesitation in treating this in one visit?
No, because by this point, in my gentle wave journey, I had been doing single visit exclusively for probably over maybe almost close to 2 years. So, no hesitation. I do all my cases in a single visit unless there's some very extenuating circumstance. Like I think I had one this year that it was so much serous exudate, like it would not, it just kept coming out. So I did not obturate that case, but every other case, pretty much I do in single visit.
That's a really good topic. If anyone wants to ask any questions on that, as I've been onboarding people, I'm finding they're still using calcium hydroxide, having them return back to fill the case. So it's a hot topic, that's for sure.
Yeah, I don't think it's ever going to be cleaner than the moment you take the gentle wave off and microsuction the canals or saline rinse the canals. Can you read that?
Sure. In case where you have the abrupt apical curvature of the canal, like this one, and sometimes cannot get instrument to length, are you able to get to length with gentle wave?
Yes. So, a case like this, if I make a very mild bend in the file and it doesn't go straight to the apex with my apex locator, I stop at that bend. I don't try to mess with it. I don't try to rebend and poke around. In my mind, I'm doing more damage to that apical tooth structure than just letting the gentle wave clean it without me messing around. I like to call this chemical patency. It's not mechanical, okay? Like I'm not taking a mechanical tool and poking the periodontal ligament, but I'm chemically cleaning because if there's canal space there, the gentle wave will clean it. So I will give it a minimal attempt to pre-bend a file and try to get that solid beep on the apex locator. But if I don't get it within like a few seconds. I obviously have my cone beam, so I know what I'm looking for and whatnot and how long approximately I should be at. So if I don't get that almost immediately, I'll just instrument to that working length.
And then Karen, I've been noticing after gentle wave is completed, some people then place hypochlorite in their syringe, go back into the tooth in some ways. Do you do anything after gentle wave is completed? Do you do any extra irrigation or file manipulation?
I do saline occasionally if I have a bleeder, but it doesn't happen very often. And also there's occasionally a time, like I had a case today that I kind of knew there was a fourth canal, but it was kind of a really weird one where it was really close to the palatal canal and it was like a fused root. I couldn't really kind of get down it. It was a number two. It was a tough angle, and I knew it joined the main mesiobuccal. So when I did my gentle wave, I actually could see very clearly, more so clearly, that it was right there, and I thought I could get a file down it at that point, because the tissue had been cleaned out and whatnot. So in it, occasionally, and an exact example of this happened today, but very occasionally will I see something new that gives me the desire to go back in with a file. So in that case, I used a little hand file just to kind of make sure my sealer would get up. I brand new hand file and I just irrigated with some sodium hypochlorite and then finished my case.
Great.
But not very often. That's pretty rare, Wendy.
Sure. And then do you always run the gentle wave for the entire time? And do you know the rationale for why the solutions are set for the amount of times they are?
So I do run it for the entire time unless something happens like I draw air or I can't, and I can't figure out how to fix the problem. Um, because why not? I feel like the reason they chose those numbers is that's the that's the bench top research that they required. And Wendy, you can probably speak to this better than I can, but I don't ever run a shorter cycle for the sake of running a shorter cycle. My assistant's in there, I'm drinking coffee, like or doing another exam or getting a patient numb or whatever I'm doing. So for me, there's no reason to, but I'm also using the 5%, and I feel like everyone should be because there's no reason not to use the 5%.
And
But
that
maybe
is
you can
just,
comment on those studies.
yeah, I mean, everyone's like, can we get it down to 2 minutes, right? That would be a game changer, but so far our research in vitro at Sonendo has shown that that seems to be the amount of time that will help kill the endotoxins, biofilm, and we're working on do actually people want to extend the time a little bit more? Do they want to shorten it a little bit more? Do you want more flexibility? So Pro Control with the G4 as software comes out is going to give you the ability to, one day really use the solutions in the way that you want.
Great.
Okay, some more questions here. Sometimes the sound that is heard during a good seal changes mid-procedure. And is that why? So I think I could speak on that. I don't know if this happens to you. Sometimes we get a little bit of sputtering. I'm not sure if that's what you're talking about, where the sound will just change for a second and then go right back. Some of the some clinicians are noticing that. We've studied that extensively and found it's not affecting the seal or the cleanliness of anything. But if Raksha, you want to email me and talk more about that, please do. Want to see videos on that and make sure that I'm representing that well too. So she responded, no, it persists and bubbles seam in window.
That means you don't have a closed
Not a
system.
good seal. Yeah.
You need to you need to
Platform.
troubleshoot your platform or see there could have been decay under the crown. There could have been um, moisture at your platform and you've lost the seal. It could be the sinus. It could be, there's so many things it could be. And we have entire lectures on that topic because it's a really good topic. So, um, Most likely, it's probably decay under your restoration. That would be when that happens to me, it's most often that. But it could be technique too, like if you're not building the platform like on a dry field, or if you're not using enough material and there's voids and whatnot. So if that's something you would like help with, I'm sure that um, Wendy can talk to you, your
Right.
clinical specialist can talk to you. We can do a peer-to-peer, like I can talk to you, I mean, whatever, but it shouldn't happen.
Great. Okay, so back to the cases. Let's see. Do you struggle with obturation with small gutta percha and minimal instrumentation? Gutta percha bends, and I feel like a steep learning curve with the obturation.
The answer is a yes. It's a learning curve, 100%. It's hard to do. That's why, like, I didn't go from day one, like, all of a sudden minimally instrumenting my canals and using these 15 size gutta perchas. My obturation technique that I use today has been a slow build of constant growth mindset over the course of years. So, like, um, I used to do, um, an F2, F3 um, instrumentation before gentle wave. Then, I went down to F1. I was like, well, why am I tapering this so much? So then I went to minimal taper. I still would stop at an S2 before I went to minimal taper. So, I mean, this is a learning curve that, it takes time. And ultimately, my technique is I use Slim Shaper ZS2 as my final file. And then most of the time, the gutta percha I use is a True Anatomy yellow cone. I think it's a 20 True Anatomy by Dentsply that fits really well with the Slim Shaper ZS2. There are times when my canal is bigger, even though I'm using a ZS2, maybe my canal, like this one, is clearly huge. I will try in a couple different cones and see if, the biggest one that's going to fit that doesn't go right out my apex is the one I want to use. So, but typically if I'm finishing like this mesial root with a ZS2, that's going to be a True Anatomy yellow, like a 20 sized gutta percha cone. And it
Great.
doesn't bend that easily. It's not like a fine fine where fine fines are tricky. They're really flimsy. I know you said the word flimsy, I believe. I don't like flimsy. I don't like them buckling. This True Anatomy, it slides like butter. It's so good. So something to try if you want a more conservative one that
Great.
doesn't bend so easily.
All right, let's get to more of your lecture. Thank you.
Okay. This next case, um, we're going to take a poll. This might be our last poll. This is a case the patient has a little discomfort, pain to biting, root canal's old. Number 19, obviously. It looks like maybe some decay or maybe crown margin is not doing great. It's got some apical pathosis. It's got a furcal radiolucency kind of on the distal side of the distal lateral root of the mesial root. Um, and our options here are we can retreat. There's the option to do surgery. We could retreat and do surgery, though I don't think that's an option on this poll. So let's just keep it to retreat, surgery, or extract. I mean, remember the financial considerations. I'm pretty sure this crown is failing. So this patient's looking at a retreatment or surgery and a new crown. If it's, maybe a strip perf repair, hard to say why that lesion's there in the furcation. Obviously, we just have one slice of the cone beam, so just do the best you can. All right. So this is more ambiguous, right? Okay, it's a tough one. Retreat 57%, apical surgery 17%, extraction 26%. Yeah, I don't disagree with any of those options. Like I said, I have 10 endodontists in a group that I was in, and we would talk about this case, and we'd probably be like one third, one third, one third. So that's, um, not this is not exactly 1/3, but it is definitely something that is more ambiguous. So, what we ended up doing, I discussed this with the patient, and because the crown and this possible strip perf, this patient decided to extract the tooth. So, again, spooky teeth. We can't save them all. Sometimes we have to make difficult decisions. Sometimes, ultimately it's our job to educate the decision, or educate the patient, help them make a decision that is best for them at that point in time. All right, case 6, we got the Avengers. This is a case that came to me, and the patient, her chief complaint was palpation tenderness on her palate. Okay, so number 3, we can see this lesion here. Here's the cone beam, huge apical pathology, but particularly the palatal root is fenestrating through the cortical plate, and that is where she feels the pain, is on the palpation of the palatal root of number 3. So, what do we do? Well, I talked to the patient. She wanted to save the tooth, and I was 100% on board. So we did the gentle wave. I found 4 canals. This is my cone fit film. I finished the case. I was pleased. And 2 weeks later, the patient came back. It's still palpation tender. So, what are we going to do? Again, decision making with these spooky teeth. We can do an IND. Maybe there's just something in there that's festering that needs to be released, and we can curette it a little bit and saline rinse it and oxygenate the area, and we can kill those bacteria. We can try an antibiotic as well. What about apical surgery? So I talked to the patient about these options. She wanted to try the IND first and the antibiotic. So we numbed her up, we lanced it, we curetted it, saline rinse, got some good, nice gunk out of there, and she went on her merry way. 2 weeks later, still bothering her. So we're now going to consider apical surgery. Well, guess what? I don't love palatal surgery. So I referred this wonderful woman to my colleague about 35, 40 minutes up the road, Dr. Ali Vadahi, who does a lot of surgery. I'm not sure if Ali's on here, but if he is, great job. He took good care of my patient. He did surgery, all roots. He did a palatal and a buccal approach, and he took a huge biopsy, and it was a periapical cyst. And so, debate obviously all you want about whether that could have healed without the surgery, but we opted to go that route, and patient's doing great. This was recently, so we do not have a recall, but I'm pretty sure she's gonna do really well with it. So, in my experience, surgeries heal very well. Um, any questions?
That's
Some of you are
super
probably
interesting.
losing your mind right now. I can't believe you referred your patient to another endodontist.
No, that's so important, Karen. Like, talk about that a little bit.
Yeah, so I don't do it all the time, but I do it in cases where I really feel like I am not the best person to treat this. And I probably, if I were going to treat this, I would have probably just treated the palatal, and I would have seen what happened, because the thought of doing that involved of a surgery for me is extremely daunting. And so I know my limitations. I trust Ali. He trained under Dr. Torabinajad at Loma Linda, and he's a skilled surgeon. So I've been in a study group with him. I know his skill because I've seen his cases, and it's something that I do surgeries, but I'm selective about them. I'll do maxillary premolar to premolar, or I'm sorry, I should say first molar to first molar. Anterior, lower, I do anteriors, maybe premolar. It just depends on the lower, but definitely canine to canine for me on the lower. And mandibular molar surgery, I've done a lot of them, and I just don't. They stress me out. I just don't really want to do them much,
Thank
and
you.
I definitely don't want to do a palatal. So, I'm just here to be vulnerable with you and let you know that he's better at it, and I'm happy to let him take care of my patients when it's necessary.
So appreciative you brought that up.
Yeah. So, um, Yes, sinus communication with gentle wave all the time. Not a problem. It's negative apical pressure, and it does, the only time it will cause a problem is if I am aggressive and I stick a file out too far and make a small hole in the Schneiderian membrane, and then I don't have a closed system. So that is the only issue I have ever had with a sinus is when it's my fault when I go in too far and I over instrument. And if I stay short, if I stay to length, not a problem.
Well, that was a little, so that's interesting. Do you go to length on those or do you stay a millimeter back on something
I
like
try to go as close to length as I feel comfortable. So if there's a thickening of the mucosa, then I go to length. But if there's not, if it's real close, or if it's like one of those ones where it's coming through like this, I will be more conservative.
right?
I just want to be able to run the gentle wave. That's my entire goal. Um, of the procedure. So if I think the sinus is going to be an issue, I'm more conservative. If I don't think the sinus is going to be an issue, I literally don't even bat an eyelash at it.
Are you the same with the IAN nerve? Someone's
I'm a little
asking.
more conservative with that because obviously, well, I'm not worried about extrusion. I'm not worried about extrusion of bleach. I'm worried about extrusion of sealer. And Gentle Wave creates perfect chemical patency on all my canals. So I'm more conservative with injection of my sealer, not with the Gentle Wave itself.
So with the IAN mandibular second molar, are you going to stay a millimeter back or still go to working length with your files?
I would go to working length or half a millimeter, but I would be much, much more cautious with my sealer placement.
Right.
All right. Any other questions about this wonderful case Dr. Vadahi helped me with? Anyway. All right, let's talk about another one. This is Ghostbusters case. I know we're running out of time, Wendy. Just tell me when to stop, but I think I have like one or two more.
Keep going. You're doing great.
Okay, so this case is another root canal failure. It's a number 3 case that I knew the minute I saw it, it was a missed canal case, and I love treating missed canal cases because they're like slam dunks for us, right? Um, so I told her, yeah, let's go in. We're gonna retreat the case. We're gonna, it's just mesiobuccal root. It was clearly like the canal that was filled was off-centered. The lesions angled to the mesiolingual of the root. It was like a typical missed canal. So I get in there, I take out the gutta percha, and I find the missed canal, and my mesiobuccal root's like 20, and my mesiolingual, I'm like stuck at 15. Okay, cannot get it. I'm bending, I'm like trying, can't get it. So I'm thinking, okay, this is going to be surgery. So I'm like, all right, well, let's finish the case, run the gentle wave. Maybe I'll get sealer. Didn't get sealer. Sorry, there's my lesions. Um, there's my sealer. Okay, so I didn't get anything passed, at least so I thought. So I said, let's schedule you in 6 months. I want to see how it does. She didn't come back in 6 months. Big surprise. They never do. She came back in 9 months though, which was nice. And sure enough, the lesions healed. And I see sealer in the apical third of that canal that I couldn't get that I didn't think was an existing canal that I thought was a 2-1-2 that I couldn't get back past the 2, but I see some sealer in it and I see the lesion is perfectly healed and she's asymptomatic and no surgery, just looking good. So these spooky teeth, these 2-1-2s, that gentle wave removes that, at least in a lot of cases, okay, removes that hurdle for us that we look at beforehand and we're like, ugh. Um, I've seen it time and time again. Any questions about this case?
Can you talk about the sealer tip you used in a case like that?
Yes, I use a Cavi tip by Ultradent that is a 29 gauge yellow. I use the 21 millimeter unless I have a really long canine. like today I did one that was like 29 millimeters. I pull out the 25 millimeter cavi tip, but mostly 21.
Do you ever cut that yellow tip?
No,
Okay. And how far apically do you inject sealer in cases with an IAN proximity?
not far at all. I don't want any positive pressure. I just feel the corona, like maybe coronal third.
Okay.
I don't want to bind at all. And then I just gently and slowly place my tip, my cone,
Yep.
and knock on
You're not
wood.
Yep.
I've had good fortune so far with that technique, but I'm very thoughtful when I do it.
And you're not coating the cone.
No.
And are you
I
going to
feel
use,
like the cone is being coated as it's
right.
drawing through that little spot of sealer.
And would you use regular in that case?
I don't use regular, but I
Okay,
mean,
you
I
still use
could.
iPhone. Okay,
I don't, but I could. Yeah, you could, I
okay.
guess. Case 8. This is Hogwarts. This is a case that was very calcified. Number 3. Um, it was necrotic, and I could not for the life of me, get down MB2. And I knew it was there, and I couldn't. I tried, and I did a little prayer and ran the gentle wave. And I actually, this was my check film. I actually was like shocked to see this. Um, MB2. It branched off really deep. That's why I'm pretty sure I couldn't get in it. But I was shocked to see this. So I was thinking, oh, well, hopefully this will be good and hopefully everything will go well. But no, this is 2.5 years later. She's developed some symptoms. She's got this apical resorption and this big lesion that I decided to do surgery. So this one I did do surgery myself. Ollie's like, darn. And I have a recall on it. I think I hit that's my surgery. I only did the mesiobuccal root because I knew that was the problem. And my surgery is tiny little scar. It's not fully healed, so I compared it to what it was before, and I was like, okay, it's not terrible. It's better, much, much better, and it's asymptomatic. So we're gonna continue to watch it, and the patient's happy, so that's most important, right? Any questions about this? So, you guys, gentle wave is not a silver bullet, but it does take away a lot of these hurdles that we look at with scary teeth. And it's not going to, be able to prevent all surgeries from happening, but it really does, I think, prevent a lot of them with that weird anatomy we deal with. So, while our goal is to save teeth, the decision-making process is multifactorial. It's a decision between you and the patient. It's not just the patient, it's not just you. You have to give and take with that. Educate them, help guide them, but ultimately it's their decision. The gentle wave can help save teeth that might otherwise be recommended for extraction. I've seen it time and time again. I've seen amazing bone healing. I call endodontists bone gardeners because we grow bone. If you clean it, it grows. And then don't hesitate to grab the PI for all types of cases, vital, necrotic, retreatment, perioendo, resorption, all the different types of cases, because your patients will obviously benefit in the long run. And then if I could challenge you to pick one thing that we learned today, like one tip, trick, technique, or like challenge you to maybe save a tooth that you might have seen a similar example tonight, so that you could try to save it instead of extracting, or use a tip or a trick this week sometime that might make your life easier or help facilitate saving a tooth. That is my challenge to you guys for this week. And that said, last year we were Chucky. All of us were Chucky. And this year, my daughter, the teenager, has divorced us. We are not, she has been informing us that she is not participating in the family costume. And so my heart is broken, but that's okay. I still have two others that are really excited about being Batman and all of his villains. And the dog is even going to be Harley Quinn. So we've got it lined up. It's going to be good.
I mean,
Questions. I
this
see
was
some
meant
coming
to
in.
be that you had the Halloween lecture,
I
right?
know. As soon as she asked me, I was like, oh, I know where I'm going with this. I'm going spooky. Anyway, let me
Someone was
just.
asking about, do you ever worry about recontamination after you use Gentle Wave and you're going to fit your cones with sealer? So I think maybe, do you take hypo and coat the cone with gutta percha with that before, or
No, I don't coat my cones with anything. Sealer, bleach, anything. I just I'm not really worried about recontamination. I mean, maybe I should be, but I would say that in the scheme of my 16 plus years of practicing endodontics, I've never been too worried about failure because of a cone being contaminated. I mean, that's assuming they're coming out of the container with an
right.
pathogen that is actually going to cause apical pathosis. So I think the risk is low.
Okay,
Um, maybe I'm wrong.
sure.
Maybe all my cases, you guys, are because I didn't coat my cones with bleach first. Anyway.
And she also asked when taking the cone fit, do you have any worries about recontamination when you're taking a cone fit film?
No, because you mean like saliva?
I'm not sure. Leslie, if you want to ask that, you can.
I
Just
mean, we use rubber dams, so no.
yeah.
But um
Couple more quick questions on Gentle Wave. Do you fit cones before or after Gentle Wave?
after gentle wave.
And then
Yeah,
what?
I don't do anything. I instrument and run the gentle wave, and then I dry and fit my cones with sealer and take the film. And then if everything looks good, I'm literally sear, sear, push, push,
Yeah.
backfill a little bit, and I'm done. If I need to make an adjustment, I will do it at that time, like maybe a smaller cone or a different cone. Maybe it bent when I was seating it or something. And then I'll do it at that time and take another film just, or sometimes not, but just if I think I need to confirm it, I'll take another film.
And besides Cabot, what other barriers are you using?
I use BC liner on all of my cases, unless the doctor asks me to restore the case, and then I use Lexicor. But I'm always open to new ideas with new materials. So if anyone has like something they really love, I would love you to email me.
I think she meant rubber dam barrier. Do you mean, Joanne, like gingival, how she uses her Cabot hot dog? Were you talking about something like that? Like, do you use anything else for isolation than Cabot?
Yeah, I use Orasil. So if I have
Okay.
any like gingival um like you know how our gingiva is not like a perfect line. It's got contours. So if I have a little gap, tiny gap between the rubber dam and the gingiva, I'll use Orasil to just seal that up. It's a caulking. I think it's Ultradent, maybe. And it works great. I use it on most of my cases, at least a small amount of it.
Do you plug the holes in the clamp with that too? I started doing that.
Yeah,
Yeah.
if there's leakage, if there's
Yeah.
not, then it's not necessary. But if
Yeah.
there's any saliva coming through, I don't want any, like I literally want to see no saliva from the moment I put my rubber dam on until the moment the tooth is sealed and I take everything off the patient. I don't want to see a drop of saliva. So if there's anything coming in, I fix it before I even put a handpiece to the tooth.
And what percentage are you doing that three tooth isolation? I see a lot of your cases have that.
Like 95%.
Wow.
I'll
Okay.
do like an anterior clamp if it's a single tooth that doesn't have any decay but I use it probably more than 95%.
Wow.
It's just my standard.
And when you punch that dam, do you like to leave?
No, she
Great.
punches three
Yeah,
consecutive holes that are like confluent with each other. So
yeah,
it's just like a kind of a,
win-win.
instead of it being a circle, it's kind of an oval.
Yeah. And then do you use a spoon to get it around, or do you have a special instrument you like?
No, I have the rubber, I have the frame, dam, and clamp, the distal clamp on
Yep,
all it was one piece. I put it on the distal tooth, and once I feel like it's secure, I take my fingers to just pop it over the wings, and then I pull it over to the mesial tooth, and then my assistant's already handed me by then, while I'm doing that, she's handing me the next clamp, and I put the clamp on the mesial tooth.
great.
And then I do anything I need to do with or a seal, or if I need to change the clamp angle a little bit, I'll do it at that time because everything's mostly sealed at that time, and then I'll do finishing touches.
Great. All right, one more question. If someone wants to come off mute and camera and ask, please do.
How do I explain it to my patients?
Yeah,
Is that a good question?
that's a great
That's a
question.
great question. I I'm not the first person to explain it to my patients typically. I would say my assistants are the first person to explain it because when I get the patient numb and I walk away, they have a script that they use to just familiarize the patient with what they're about to experience. You know, they're going to have a bite pillow, they're going to have a rubber square that isolates the tooth from the saliva in your mouth, and blah, 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 blah. They say about pressure washer for your tooth. That is, I've heard that used absolutely. Power washer for your tooth. But they say about halfway through the procedure, you're going to experience the gentle wave. It's an 8-minute irrigation of the tooth. It's just going to flush out the tooth. And then when I come in and I do the root canal and I've built my platform and I'm about to turn that on and they're going to hear this, I say, we're going to use the gentle wave. It's going to clean out your tooth. It takes 8 minutes. I say, it's usually uneventful, but if you have any problems, it's also very easy to pause. So just raise your hand if you need anything, and I leave it at that. And then if they ask questions at the end, I go into, more detail, or if I have an engineer in the chair, I go into more detail and I'm happy to talk about it. I love talking about it, but I've found sometimes less is more, just letting them know that it's cleaning out all the little nooks and crannies. I sometimes say sucking out all the inflammation from your tooth because it's literally sucking out everything. So, there's a lot of ways you can describe it. I try not to use any words that seem scary or anything like that because it's not scary. It's very easy and very safe.
All right, our last question tonight. Have patients had sensitivity while running gentle wave?
Very occasionally, and it's mostly my patients who have already told me that they metabolize the anesthetic quickly, or patients that I've administered carbocaine because carbocaine does metabolize more quickly. So, in those instances, a patient raises, I've already instructed them that if they have any problems, raise their hand. They raise their hand. They're like, oh, and I'm like, okay, let's get you, another carpaceta nest, and they're ready to go in 30 to 60 seconds for the remainder of the procedure.
Great. All right. Well, we are going to wrap up tonight. Thank you so much. Always a pleasure to spend time with you. And then everybody needs to know, so the webinars are the third Wednesday of every month. Our next webinar is going to be with Dr. Ryan Facer, November 19th, and is going to be on retreatments. So what is the hidden opportunity with gentle wave and retreatment? So make sure that you sign up for that. We do have a QR code here. If you want to take a picture of that, that will help you sign up quickly. And then thank you everyone tonight. Go enjoy your evening and stay warm. It's starting to feel like fall. It's feeling great. So
Happy Halloween!
take care. Bye-bye.
Bye.